Rana Kamran, can you confirm if you guys can see my screen?
Yes, Dr. Zeeshan, go ahead.
Okay. So today's session is about pharmacokinetics. This is my disclosure. I have nothing to disclose. Do I have to turn on video, Rana Kamran? I'll leave it. Okay, so I have nothing to disclose. And so the agenda for today's presentation is we'll touch base on basic pharmacokinetics relationships, and we'll talk about absorption, distribution, metabolism, and excretion of the drug. A little bit about non-linear pharmacokinetics, non-compartmental model, data collection and analysis, and pharmacokinetics in renal and hepatic diseases, which we usually do in our daily practice, and then lastly, pharmacodynamics. So before starting, I'll let you know that this is a very dry subject in terms of starting your preparation with, because we do not practice many of these relationships in our daily practice. Mostly we pharmacodynamics is a part of our practice, not pharmacokinetics. Pharmacokinetics is limited to a very few medications or few drug level monitoring, but we do not use all these formulas to calculate the doses, or when will be the next dose, what is the concentration of the drug, what is the volume of distribution in this patient. So that is why it becomes more challenging to keep up with this subject, because we don't practice it the way it should be practiced. But this is one of these speciality where pharmacists should consider themselves improving in this speciality or in this domain of the pharmacy, because this is where you can have many intervention, and this is where you can catch the physician or speak to them about pharmacokinetics, because pharmacodynamically they are more strong in pharmacodynamics, but not in pharmacokinetics. So not limiting, so idea is not for pharmacotherapy courses, not limiting ourselves to only pharmacodynamics, but to pharmacokinetics as well. So starting off with our first case, HR is receiving vancomycin for MRSA treatment, and HR has a renal failure. So he was given a dose of 1 gram on 3rd at 1200, and the concentration was drawn 2 hours later at 1400, which came as 23.8 milligram per liter. The normal vancomycin concentration for MRSA treatment is between 15 to 20, and another concentration was drawn 3 days later at the same time, 1400, and it came out 12.1 milligram per liter. It's almost half of the concentration, which was peak concentration drawn on the same day of dosing. So we can, from this equation, we can guess the half-life of the drug is 3 days. So the question is, if you were to give 1 gram dose on 3rd on 24th of 3rd of month at 1600, when would you need to give the next dose? So you gave the first dose on 21st, and at peak level came out at 23.8, and the second dose was 3 days later at 24. The level came out 12.1. And if you were to give a dose on 24th, what will be the next, when would you need to give the next dose, so that it do not go beyond the maximum therapeutic concentration? So the options are 1 day after the dose on 24th, 3 days from the dose on 24th, or 6 days from the dose on 24. 24 was the second dose, or there is insufficient data or insufficient information to calculate when to redose. So any takers, if you want to answer this question, you can give your comments in the chat section, if I can see that. Anyone? Okay, no. So we'll go ahead and solve this question. And these type of questions are the most important questions, which usually comes in board of pharmacotherapy exam. Or I'm focusing only those important aspects of the pharmacokinetics, which are more relevant to exam, not relevant to our daily practices. So keep in mind a dose concentration calculation like this one, when you have to redose, or how many days after the first dose or second dose levels and all the data sufficient to calculate the information. This question will be provided to you in question, but expect 1 to 2 questions from this type of question in your exam. So go ahead and solve this question. So first you have to calculate the volume of distribution, because that would be required in your further calculation. And this formula, which is a volume of distribution, is equal to fraction of dose divided by the initial concentration. You have to memorize this formula, because this formula gives you many information, and it can be used to calculate many things for the dosing, for the half-life, and for the concentration of the drug. If you have the dose and if you have the concentration, you can calculate the volume of distribution. So 1000 milligram was given, and 23.8 milligram per liter was the concentration, which was taken 2 hours. That is a peak concentration. So the volume of distribution of vancomycin in this patient is 42 liters. So keep in mind, volume of distribution can change in patient who has a renal insufficiency. It will not remain the same for all the patient, because one size does not fit all, even though these volume of distribution are mentioned in the drug monograph, but it is not true for all the patients, especially with the CKD patient. So if you have concentration, if you have dose, and you want to identify when to redose, when to give the next dose, you have to calculate the volume of distribution of these patients. And you also have to calculate the elimination rate constant, because CKD patient clears the drug much more slower than the normal. You can find the elimination rate constant in the drug monograph, but that would be for the normal patient or with normal kidney function. But this patient has, as in the question is mentioned, this patient has renal failure, so the elimination rate constant or elimination rate of the drug will be reduced as well. So elimination rate constant is calculated by K is equal to log of concentration 1 natural log of minus natural log of concentration 2 divided by the time difference, or T half. The famous equation for T half is 0.693 divided by K. So once you have the K, you can calculate basically the T half. What is the half-life of this drug in this patient? Because half-life also changes in patient with renal insufficiency or patient who has chronic kidney diseases. So if you put the data, the concentration 1 is 23.8, and the concentration 2 second is which was done 3 days later after the dose, which is 12.1. Natural log 23.8 minus natural log 12.1 milligram divided by 72. 72 hours is the difference between first and second dose. This will be provided to you in the questions, and it gives you an equation 0.009 4 per hour. So that is the elimination rate constant, and through this constant you can calculate the half-life of the drug as well. Now the final equation which you have to keep in mind to calculate the concentration needed to calculate when to redose. So this is this equation here, Cp is equals to Cp naught E minus Kt. This is an important equation in these kind of questions, where you have to give the redosing information after how many days you have to redose, or after how many concentration, after how many days you have to check the concentration. So this is the important equation. So putting all the values in this, this first equation here, concentration is equals to 1000 milligram upon divided by 42. This is the same equation, which is Vd is equals to F over Cp. So you get the concentration, which is 23.8, which was the first concentration taken 2 hours after the first dose. So 12.1 milligram plus 23.8 milligram equals to 36. Why we added both of these concentration? Because 23.8 milligram per liter was the concentration of the first after the first dose, and 12.1 milligram per liter was the second concentration after 3 days. So if you give a dose, it will be added on top of it. It will not be completely eliminated down to 0, and then you should calculate again, but it will be added together. So the final concentration is 36 milligram. So putting all these value into our previous equation, Cp is equals to Cp naught E minus Kt. 10 milligram is equals to 36 milligram multiplied by E raised to the power minus 0.0094. That is the elimination into time. That is time we need to calculate. If you solve this equation by taking natural log of this, it will convert E into the value, and T will the answer will be 136 hours. 136 hours, or approximately 6 days. And you can also manually calculate this equation. As you know, the T half of this drug in this patient is 3 days. How we can manually say the half-life is 3 days? Because the concentration on the day of dose is 23, and after 3 days the concentration is let me see if I have pointer. Yeah, another spotlight. Yeah. So you can see this is 23.8 on the first day, and after 3 days it reduced to half. So 3 days we know is a half-life of the drug. So sorry about this. Okay. So 3 days is the half-life. So it will take 3 days from this concentration to be down by 36, from 36 to down to half of the concentration, 18 in 3 days, and next half concentration is in another 3 days. So 3 plus 3, 6 days, and it will reach 9 milligram per liter, which is below therapeutic. So you have to redose here. Since the half-life is 3 days, and you have to wait at least 6 days to redose the patient. So answer for this question is, so you have answer is C, that you have to take 6 days from the dose on 24th. Now this concentration 10 milligram, where did it come from? Because the question did not specify that at what concentration you have to redose, or what concentration it will reach what concentration of what dose. So 10 milligram is the minimum concentration which we should keep vancomycin for the MRSA, for the treatment of MRSA. That is why we took a standard of 10 milligram. If it is mentioned 15 in the question, that at 15 milligram per liter, if we have a redose at 1 gram, what would be the next, how much, after how much time we should give another dose? So you will put 15 instead of this 10. For example, if they give after 12 milligram per deciliter, 12 milligram per liter concentration, if you redose 1 gram, after how many doses of the second dose you have to give another dose? So you can put 12 here. If nothing is mentioned, so you can straight away take the minimum dose of that drug, which is required to maintain the bactericidal effect. So in this case, 6 days is required to redose. So after second dose, you have to wait 6 days to redose this patient to maintain the concentration in the therapeutic range. So case number 2 with basic pharmacokinetics relation is, following an 100 milligram drug IV and 200 milligram of the same drug PO, the area under the curves are 50 milligram per liter per hour and 25 milligram per liter per hour. 50 milligram for IV and 25 milligram per liter per hour for the oral. So what is the bioavailability of this drug? A 25%, B 37.5%, C 50%, or D 100%? Any takers? If you want to answer this question, you can type your message or your option in chat. So as you guys know, that to calculate the bioavailability oral, or to calculate the bioavailability, we need to have the both area under the curve and dosing of IV, because we always okay, somebody answers 50 percentage. Okay, let's see, let's calculate. So IV is always the reference to calculate the bioavailability. Junaid, the 40% is not in the option, if you take it as close to B, but let's see, let's calculate. So 100 milligram of IV and 200 milligram of the same drug oral. The area under the curves for IV is 50 milligram per liter per hour, and the area under the curve for oral is 25 milligram per liter per hour. So I'm sure you guys all know this equation. You have read this equation in your clinical pharmacokinetics, that bioavailability is dose in IV multiplied by area or under the curve of oral divided by dose in oral, dose in oral multiplied by the area under the curve of IV. So 100 milligram is the oral dose multiplied by 25 milligram per liter per hour divided by 200 multiplied by 50, and that gives you the answer. Bioavailability is 25%. So IV is the reference to calculate the bioavailability. So you should always have the dose and area under the curve of both routes, IV and oral, to calculate the bioavailability of the drug. So this formula is a very simple formula. You put the values in this formula and you'll get the answer. So answer is here 25% A. I'm not sure how I can erase this this red circle here on the screen. Hold on. Update. No, I guess I cannot remove it. Okay. Dr. Kaman, can you remove this red circle mark from the slides, or you guys can see it on every slide? Are you seeing it on every slide?
Yes, sir. It's on every slide. I can try, sir. In the meanwhile, you can continue, sir.
Okay, no problem. Okay. So moving on to our next domain in pharmacokinetics is the absorption. As you all know, that drug which are taken orally, they undergo first pass effect, first pass metabolism. They are absorbed into the gastrointestinal tract, and then they pass through the liver through the blood, and they undergo metabolism for activation, or to be simplified enough to be excreted from the body. So that is why the bioavailability of oral obviously is low, because many of the drug is metabolized into some of the drug is metabolized and some is excreted. Buccal and some other rectal blood also bypasses liver. So any medication which is given through the buccal route or sublingual route, they bypasses the first pass metabolism, and some rectal blood also bypasses the liver, so they are not prone to first pass first pass metabolism. So drugs, there are some drugs which are excreted in bile, like ceftriaxone, as excreted into the bile, metabolized by the normal. Some are metabolized by the normal flora and reabsorbed back into the circulation, and some drugs are expelled by the gallbladder and on-site smell ingestion of food, like ursodeoxycholic acid. So first pass metabolism inactivates the drug, and there are two phases of enzymatic reaction that you all know, phase 1 and phase 2, which are responsible for the metabolism of the drug, for converting the product into the active drug, and that's where the oral bioavailability of the drug is reduced. So drugs are oral, which are active, which are metabolized, and products are converted into the active metabolites. They are also protein bound. Many of the drug, almost all of the drugs are protein bound, and albumin is the most common binding protein of all the drugs. So drug which is freely available, unbound state, free available, that is available for the therapeutic action. And P-glycoprotein is also a protein binder, or a pump which binds basic drugs, and it is also responsible for binding of the drugs. So case 3 is what about P-glycoprotein? It is a plasma protein that binds basic drug, it's transferred drug through the GI mucosa, increasing absorption.
Dr. Zeeshan?
Yes.
Sorry to interrupt you, sir. To remove that circle, please use that pencil-like icon at the bottom of your screen, if you have it.
I have this annotate. Yeah, it opens a pencil sign, and it gives me draw option.
Does it give you an erase option as well?
Yes. Yeah, it has.
Yes. Yeah. Okay.
Thank you, Rida. Thank you very much.
No problem. You may continue, sir.
Okay, so P-glycoprotein transfer drugs to the GI mucosa, increasing the absorption. It diminishes the effect of CYP3A4 in the GI mucosa, or it is an efflux pump that decreases GI mucosa absorption. So P-glycoprotein is basically it works in the GI mucosa to decrease the absorption, and it is a efflux pump that pumps the drug back into the GI lumen absorption, GI lumen, and it affects the drug interaction. Most CYP3A4 substrate are also P-glycoprotein substrates. So if the drug is metabolized through the CYP3A4 enzyme, they are mostly bound to P-glycoprotein, and they are also their substrate. Many CYP3A4 inhibitors and inducers, the drugs like cimetidine, which is a CYP3A4 inducer, it also induces P-glycoprotein, or the drug which are CYP3A4 inhibitors, they also inhibit the P-glycoprotein. Examples are dabigatran, digoxin, and HIV protease inhibitors are affected by various inhibitors. So they mainly their pump, there is absorption and drug pump back is into the GI lumen is by the P-glycoprotein. So other medicine which induce or inhibit the CYP3A4, they also induce or inhibit P-glycoprotein, affecting the concentration of these drugs which are mentioned here: dabigatran, digoxin, HIV protease inhibitors, and so volume of distribution is a constant, which is also a very important parameter in pharmacokinetics that you will have to calculate in almost all calculations of half-life, of elimination rate constant, of finding the concentration, or finding the when to redose. So volume of distribution you have to calculate for almost every drug. So it is a constant that relates the amount of the drug in the body to an observed concentration of the drug. The formula of VD is equals to fraction of dose upon the concentration of the drug, initial concentration of the drug. So as we discussed, distribution protein binding is mainly by albumin. 95% of the drug are albumin bound. Alpha-1 acid glycoprotein, lipoprotein like P-glycoprotein are also major protein drug binders, and drug bound to them, which affects the absorption and bioavailability of the drug. And so another case is a renal transplant with community-acquired pneumonia, and the patient is on cyclosporine, which is the least likely to interact. Erythromycin, clarithromycin, azithromycin, or all macrolides inhibit the CYP3A4. Macrolides are known CYP3A4 inhibitors. So what do you guys think? A renal transplant patient with community-acquired pneumonia, and patient is on cyclosporine, which is also a substrate for CYP3A4, and erythromycin macrolides, clarithromycin, azithromycin will inhibit CYP3A4, increasing the concentration of cyclosporine. So which of these can be easily prescribed with cyclosporine to treat the community-acquired pneumonia and without much affecting the cyclosporine? Okay, Junaid Khatak sent me a direct message. Did not send a message to the group, but his answer is correct. Junaid, okay, so let's see. Yeah, so the clearance of the drugs is mainly because due to metabolism by cytochrome P450. It's a group of heme-containing enzymes responsible for phase 1 metabolic reaction, which are hydrolysis, oxidation, and reduction, located in the endoplasmic reticulum, in the liver, in the small intestine, in the brain, lung, and kidney. Drugs generally have a high affinity for one of the CYP450, but maybe utilize secondary pathway. Like for example, one drug may be a substrate to CYP3A4, 2D9, 2C19, like omeprazole, warfarin. They are substrate to more than one. And sometimes the drug has different enantiomers or isomers. One of them is substrate to one of the enzyme, and the other one is substrate to another enzyme. For example, warfarin and clopidogrel, if I'm not mistaken. Warfarin has different R enantiomer and S enantiomer, which are substrate to different. But a drug can be affinitive to only one type of CYP450 enzyme, or it can utilize secondary pathways as well. So CYP, as we know, cytochrome P450. CYP is a superfamily, and two, these are the families. And then C, after that, alphabet C, D, A, these are the subfamily, and And number in the end is the isoform, like CYP3A4, CYP2C19, 2D6. So these are the different enzymes. So cytochrome P450 characteristic, they inhibit substrate independently, and some substrate are metabolized by more than one CYP 450 enzyme, as I discussed before. Enantiomers may be metabolized by different CYP450, as I discussed about warfarin. They have different enantiomers. They can be metabolized by different CYP enzyme families. And difference in inhibition may exist in same drug class. Like, for example, one drug may follow a metabolism pathway from CYP3A4. The other drug may follow 2D6 or 2C19, like in the cases of proton pump inhibitors. Many of these, like each of these drugs have a different pathway, more than one. One is predominantly metabolized by one enzyme. The other one is metabolized by predominantly another enzyme. And same is the example in the question which we asked, macrolides. One is metabolized less to a less extent. So this is we discussed. Okay. So the renal transplant with CAP patient on cyclosporin, which is least likely to interact, the answer is C, azithromycin. Erythromycin and calithromycin are they'll inhibit. They are strong inhibitors of CYP3A4, while azithromycin is different among this class. It is not a substrate, or it does not inhibit CYP3 that is strongly. So it can be safely given with cyclosporin without altering the levels of cyclosporin. So we have another case moving on to the next domain. WT is a 62-year-old man, chief complaint of chest pain, diagnosed with STEMI, cath lab, drug eluting stent 2 placed, and new medicine, aspirin 81 mg, clopidogrel 75 mg. Other meds includes losartan 25, carvedilol 25 twice daily, amitriptyline 100 mg daily, acetaminophen 500 mg as needed, and simvastatin 20 mg daily. Simvastatin, as we know, is also strong inhibitor of CYP3 family. So pharmacogenetics also play a role in the metabolism of the drug. Many of these drugs have a patient who has different genetic variants or alleles. They metabolize the drug differently. The concentration of drug differs in this patient who has these genetic variants or alleles, or they are also prone to a serious adverse drug reaction for that drug. But it's identified in less than 1% of the population. So phenotype is the clinical expression of the trait, and genotype is the genetic composition. So there is a clinical pharmacogenetics implementation consortium. This is designed to facilitate the translation of pharmacogenetics information from research to clinical practice. So with this approach, that one size does not fit all, this consortium takes the pharmacogenetics information that we have researched into the clinical practice, how we can utilize this information to dose our patient. And they develop guidelines for the utilization of pharmacogenetic testing results in drug dosing, focused on a specific drug and gene pair. These are the list of medication which has patient has different gene variants of these alleles, and if they have these different alleles, then these drug dosing are different for those patients, or it's better to avoid these drugs into those patients. Like, for example, allopurinol, if the patient has HLA-B variant gene, so then this is better to avoid, because patient may have a serious drug interaction or adverse drug reaction. So taking the example of clopidogrel, so this CPIC, mentioning example of clopidogrel, it requires a metabolism by 2 CYP2C19 to active metabolite, which is responsible for the antiplatelet activity. So CPIC recommendation: normal dosing for ultra rapid metabolizer, alternative antiplatelet therapy in immediate or poor metabolizer. So CM is there is another case. CM is a 55-year-old man, started on phenytoin 200 mg daily post craniotomy. So recent steady state concentration is 6 mg per liter. So steady state concentration, this is also another concept Many times you will find that some drugs are monitored based on their trough levels, and some drugs are monitored on their steady state concentration. How would you identify, or how would you define that this in this drug we have to take a steady state concentration, or another drug we have to take the trough concentration? So there is a general rule: if the half-life of the drug is more than the dosing interval, so then this drug is going to achieve steady state concentration, and we have to follow steady state concentration. And in second case, when the half-life of the drug is less than the dosing interval, then you have to follow the trough concentration. Like for example, aminoglycoside, like take gentamicin for an example. Gentamicin is usually given as once daily, but the half-life of gentamicin is 3 to 5 hours. So within 3 to 5 hours, drug concentration will be reduced by half. In another 3 to 5 hour, drug concentration will be reduced by half, but you redose a patient on 24-hour basis. So here the T half, the half-life of the drug, is less than the dosing interval. So you can take trough concentration in this patient. And for example, amiodarone or warfarin or digoxin, where the concentration or where the half-life of the drug is higher than or more than the dosing interval. For example, digoxin has a half-life, if I'm not mistaken, more than days, 5 days, but you redose a patient every day. Amiodarone has a half-life of, I believe, weeks, but you redose the patient every day, or sometimes BID or sometimes TID. So in this case, half-life is greater than the dosing interval, so you take the steady state concentration. Same is the case with phenytoin. The half-life is more than the drug dosing interval. Usually it is given 3 times a day or once daily. So that's why we take the steady state concentration. And in cases of phenytoin, the normal dose ranges from 10 to 20 milligram per liter, and this patient achieve a steady state concentration of 6 milligram per liter, which is less than the normal. But moving on to the case further, we'll see if there is any change. Okay. Okay, so if CM KM or is calculated to be 5 milligram per liter, what will most likely occur if the dose is doubled? So as we also know that phenytoin follows a non-linear pharmacokinetics or zero-order kinetics, where the drug absorption is not dependent on the initial concentration of the drug. That means the drug has poor and erratic absorption. Non-linear pharmacokinetics or zero-order pharmacokinetics is like it's not predictable. If, for example, you give 100 milligram of a dose to 10 patients and you have to take a level after 2 hours, all these 10 patients will have different levels. So this is a non-linear pharmacokinetics. This is a non-zero order pharmacokinetics, where the absorption of the drug is independent of the initial concentration of the drug, which is opposite to the first order kinetics, where the absorption of the drug is dependent on the initial concentration of the drug. So if CM patient KM is calculated to be 5 milligram per liter, what will be most likely occur if the dose is double? A, his concentration will be double, since phenytoin clearance is linear above the KM. His concentration will be more than the double, since the phenytoin clearance is non-linear. His concentration will not change because phenytoin is an autoinducer and clearance increases with time. His concentration will increase by only 50% since phenytoin absorption decreases significantly with doses greater than 300. So in this case, let's see, it's a non-linear elimination. Phenytoin is a zero-order kinetics drug. It follows non-linear pharmacokinetics. Other drugs which follows non-linear kinetics are theophylline, digoxin, some salicylates, ethanol, heparin at some, and aspirin at very high doses follows non-linear kinetics. So it's Michaelis-Menten equation. This question usually does not come in the exam. I have never seen or never heard of this exam, but you should know. In nonlinear elimination, Michaelis and Menten equation is used. Rate of elimination, which is Km. Rate of elimination is equals to Vmax, the maximum concentration plus Km plus C. So non-linearity occurs when the concentration is or at or above Km. So the concentration of the phenytoin in our patient is 6 milligram, but the Km is 5 milligrams. So the concentration is above the Km, so non-linearity will occur. So this patient will have, his concentration will be double since phenytoin, his answer is B, his concentration will be more than double since phenytoin clearance is non-linear above the Km. So you cannot predict that what will be the elimination, it will remain the same or not. So next domain in data collection, non-linear pharmacokinetics is very typical. It's not used in our clinical practice because in our clinical practice we follow the levels. We don't use these non-linear equations. So most probably there are higher chances that there will be no question from the non-linear kinetics. But you should practice it. You have to practice. It's like maths. So you have to do. I'm sure the team has shared with you the workbook for pharmacokinetics, and in workbook of pharmacokinetics there are many examples, there are many equations, and there are many drug calculation problem to solve. If you solve those equations, it will be much more clearer to you and you will be able to do it. So you have to do it in the start, you have to do it at the end. Do not consider it one if you have done it in the start that you will remember it till the end. So just a tip for your preparation, what I did started with the clinical pharmacokinetics, did the calculation, understood it, and I kept on repeating it every 2 or 3 months that I should not forget it. So data collection for analysis, data collection most relevant to this pharmacokinetics is the sample collection. Timing of the collection is very important. Ensure the completion of absorption and distribution. You cannot give an oral dose and take a level within 5 minutes because you have to allow 1 to 2 hours for the complete absorption and distribution of the drug, because once the drug is given orally, it is taken to the liver for first pass metabolism. After whatever the drug is in the proform or the active form, it reaches the blood and it binds to the albumin. Only the free drug, it binds to the albumin. If it is a lipophilic drug, it will be distributed in the adipose tissue. If it is hydrophilic drug, it will be distributed to the interstitial volume. So you have to allow the absorption and distribution time, and then you take the level, which will be the true level, and the free unbound drug, which is available for the therapeutic action. Ensure completion of redistribution post hemodialysis, especially with high flux or high efficiency drugs like aminoglycoside. Their redistribution changes post dialysis. Many of the drugs, their redistribution is changed post dialysis, because after a dialysis session, if a drug is partially dialysable or say 50% dialysable, so many of the drug will be removed during the dialysis session. What happens when the dialysis is stopped? The drug will redistribute itself in the body, because it has to keep equilibrium into different compartment of the body. If you remember the different compartments, there are 3 compartments: fat, plasma, and serum. So if a drug is less in one compartment, it will be redistributed from other areas. So after a hemodialysis session, especially high flux and high efficiency drug, which are highly dialyzed, there will be redistribution. So you should not take a level just after hemodialysis session. So you should give at least 2 hours for the redistribution to occur, and then you can take the level. So specimen requirement, you have to take the whole blood, plasma, or serum, where you have to calculate or identify or measure the concentration of the drug. That is also an important factor in drug concentration monitoring. Assay terminologies, there are some assay terminologies which are used, and this is very relevant to our exam. There can come a question from this. There is precision, which is reproducibility, standard deviation versus coefficient of variance. Precision is like if you do 100 times the same test, it will give you the same, the result is reproducible. You'll get the same amount of result with the acceptable margin of error of plus minus 5%. Accuracy and predictive performance, then which you can predict the performance of the measure of the accuracy. Sensitivity, you have heard a lot, this test is sensitive but not specific, this test is specific but not sensitive. So these are the assay terminologies which are used in data collection and analysis, and you can have one question from this in your exam. So for example, A drug assay is touted as having high specificity but low sensitivity. What does this mean? A. The assay can distinguish drug from like products but detects extremely low concentration. The assay can't distinguish drug from like products nor detect extremely low concentration. The assay can distinguish drug from like products and detect extremely low concentration. Or D, the assay can distinguish the drug from like products but cannot detect extremely low concentration. I believe this is very common in our daily practice, so you should be able to answer. If any takers, you can mention your answer in the chat section. The drug has high specificity but low sensitivity. Anyone to answer? No. Okay. Okay. So Muhammad Farooq Anwar sent me a direct message and his answer is right. So, okay. So specificity is the basically a test can distinguish a drug from like products. For example, esomeprazole, omeprazole, pantoprazole, lansoprazole. If a test can identify that which drug is this because their structure are very similar, so this is a highly specific test which can identify, okay, this is esomeprazole, this is pantoprazole, this is or this is azithromycin, this is clarithromycin, this is erythromycin. If the drug can identify between like drug, then it's a very high specificity, but it cannot detect extremely low concentration. So it has to do with sensitivity. If a drug test is sensitive and has a low sensitivity, that means it cannot detect extremely low concentration. So this drug assay, which we are talking in this question, has a high specificity but low sensitivity. So answer is D. This assay can distinguish drug from like products but cannot detect extremely low concentration. So similar kind of question can come in your exam. Okay, so assay methodology, there are different assay which are used for the concentration, and there are radioimmunoassay which are extremely sensitive, and disadvantage, it has a short half-life because it uses radionuclei and it has a nuclear waste and which has cross reactivity. Enzyme immunoassay, AMET technology is also used for the drug concentration identification. They are highly sensitive, they are stable, they are automated and simple, but the measurement is more complex in these tests, and the background, there is a background interference with the enzyme that is used for this. Then we have fluorescence immunoassay. They are also simple, highly sensitive, stable and simple, but they also have background interference. This does not has to do anything with us. It is more related to the lab professionals, but you should know that these are the assay which are used. It will never come in exam. So there are other assays which are used in pharmacokinetics research studies. Those who are related to STUDS, they know that HPLC, gas chromatography, mass spectrometry, liquid chromatography, and bioassays and flame photometry, they are very commonly used in the research studies and assay and analysis of the drug. So moving on to another case, KM is an 80-year-old woman, 52 kg, 5 feet 4 inch height, and she is admitted for pyelonephritis with sepsis, past medical history of myocardial infarction, CHF, HTN, osteoporosis, RA, and CVA. Her serum creatinine is 0.92 milligram per deciliter, which we know it is in the normal range. Her albumin is 2.9 gram per deciliter, which is a bit low. So she's on drug Septran 280 milligram IV every 12 hours, lisinopril 10 mg, digoxin 0.125 daily, Lasix 40 mg daily, cimetidine 400 BID, acetaminophen 650 Q6, calcium carbonate, and carvedilol 6.25 PO BID. So which is the best assessment of KM renal function? A, her serum creatinine is in the normal range and no dose adjustments are necessary. Because of her age, KM has some degree of renal dysfunction and doses may need to be adjusted. C, because of the pyelonephritis, KM has a renal dysfunction and doses may need to be adjusted. D, her serum creatinine is in the normal range, but her burn is elevated, so doses may be need to adjusted. Any takers for this question? This is simple enough. We daily encounter in our practice. I'm sure you guys can answer this. So any clickers? Okay, so as you can see from the question, there is too much information. Okay, let's see, Mohammad Farooq again give answer. Let's see another one. Let's see what is so this is a very common in board exam question. See, question gave you a lot of information. Question gave you past medical history and what is patient admitted for, her height, her weight, which is relevant to this question. Serum creatinine is relevant to this question. But if you see the drug, it's a long list with doses. So it will take you a lot of time to read this question. But when you reach to the main question, it will be totally different. So in this case, if the question does not have this drug information part, that what drug she is on is okay, we can still answer this question. But to complicate things, they do like this. They give you a one-page question and the question will be totally different. So answer in this case is B. Because of her age, KM has some degree of renal dysfunction and doses may need to be adjusted. Why? Because we know that after 50 years, every 10 years, the kidney function and heart function drop by 10%. Even though the creatinine is normal for this patient, 0.92 milligram per deciliter, but this is a 80-year-old female with only 52 kg of weight and 5.4 height. Height does not matter more here in Crocroft and Gault equation, but 80 years with 52 kg female with 0.92 creatinine, obviously her creatinine clearance, if you calculate now 140 minus age into weight divided by serum creatinine clearance into 72 into 0.85, definitely her creatinine clearance or GFR would be less than 30. At this creatinine clearance, obviously you need to adjust doses for many medications. So the best answer here is not because of pyelonephritis, it's because of her age, because she is geriatric 80. So she has some degree of renal dysfunction because of the age, not because of any functional problem in the kidney. So because of her age, KM has some degree of renal dysfunction and doses may need to be adjusted. So B is the answer in this case. So which of the KM drugs may alter serum creatinine concentration? Lisinopril and digoxin, trimethoprim and sulfamethoxazole, and cimetidine, furosemide and calcium carbonate, acetaminophen and carvedilol. So there are some drugs which can alter the serum concentration. So let's find out which are these drugs. So estimation of kidney function, we usually use Crocroft and Gault. It is usually done by 24-hour urine collection or by checking the serum concentration of creatinine. It is the most commonly used equation for the renal function, though it is not very accurate in extreme cases like in pediatric cases or in geriatric cases. But because it is being used for a very long time and the drugs which we are using and which are available in the market, unfortunately, they have their renal dose adjustment based on Crocroft and Gault. That's why we have to use this. There are many research carried out on this equation. That is why we have to use this. Otherwise, the more accurate estimations of yes, Junaid, the answer is B. Because of the answer of B of the previous question, because of her age, she has kidney dysfunction or some sort of renal dysfunction. Okay, moving on to this PK and renal disease. So MDRD equation are the standardized creatinine equation. They are the more accurate. CKD epi is also the accurate one, but unfortunately we have to use Crocroft and Gault because most drug monograph has the information or dose adjustment based on Crocroft and Gault. So we know a very common formula, 140 minus age divided by weight into serum creatinine, multiply by 0.85 for female. And Schwartz equation is usually used for pediatric, which is K into, I don't remember the equation, but you can find this on internet. So factors that influence renal disease or estimation of the creatinine clearance is the disease state itself and clinical condition. Diet, if the patient is on high meat diet, obviously patient will have high creatinine. There are certain drugs which are or endogenous substances which has a pharmacokinetic interaction and they alter the creatinine synthesis or creatinine formation. And there are also some laboratory interaction. Disease state like hepatic disease, hepatic dysfunction, chronic kidney disease, they alter the creatinine clearance. So drug dosing in renal disease patients. So this question we get many times from our physician. The patient came, a patient is CKD stage 4, came with infection. I want to give antibiotic. What dose should I give? Should I give adjusted doses or should I give the full load full dose first? So always, if you get this question from the physician, even if the patient is anuric, producing zero urine and as infectious patient, septic patient, and physician asks you about the dose, never ever advise physician to give first dose as a low dose or a adjusted dose. Always give the first dose or even the first day full complete doses, because as we discussed before, for the to allow the readjustment or redistribution of the drug concentration into adipose tissue, into the interstitial fluid. Because if you give a low dose in the first day or the first dose, drugs will obviously be distributed into different compartments, and there will be very low drug will be available for the action. So we want to avoid that. We want to treat this patient upfront with high dose, so that enough free drug is available for the action. Maintenance dose you can always decrease, which there are two ways to adjust the maintenance doses, either by changing the dosing interval. You can increase the dosing interval, like for example, if a drug was given as 8 hourly, you can do it 12 hourly based on the monograph, or you can change the dose. You can use the same interval, but you reduce the dose, like 1 gram 8 hourly, and you reduce it to 500 milligram 8 hourly. So both are possible depending on the drug, and it can be easily found in the monograph. So renal disease estimation, these are some formulas which you can find easily on the internet, or I'm sure you guys know this, no need to waste time on this. Okay, so SJ is another case for hepatic. SJ is a 55-year-old man with fungemia, past medical history of hepatic dysfunction, ascites, no encephalopathy, started on caspofungin, decreased dose in patient with Child-Pugh, a score of 79. Labs are AST 85, ALT 56, ALK phos 190, total Billy 1.8, albumin is 2.9, LDH 270, PTINR 14.6 and 1.7, and GGT gamma glutyl transferase is 60 units per year. So we have to calculate the Child-Pugh. If the score is 0 to 9, we have to decrease the dose of caspofungin because it is hepatically cleared. So what is the Child-Pugh score in this case, in this patient? 3, 5, 8, or 11? Let's see the answer. There is a chart which we have to consult to calculate the dose on hepatic, to calculate the Child-Pugh based on the information provided, and based on different moderate, mild, moderate, or severe, 3 to 5, 5 to 7, 7 to 9. Based on these numbers, we have to adjust the dose accordingly. There are very few medications which are hepatically adjusted. Many of the drugs which are hepatically cleared are also not adjusted. So especially the drugs which have high ER ratio, extraction ratio, they are adjusted. So start slow and increase the dose slowly in hepatic cases. So how we calculate the points? We give a point for each of these. If the patient has encephalopathy, you give 1 or 2 points, depending on 3 or 4 points, depending on the grade of encephalopathy. Ascites 1 point, 2 point, and 3 point, depending on the how bad ascites is. Albumin level less than 1.5, one between 1.5 to 2.3, or more than 2.3, you give 1, 2, 3 points. Albumin, based on that you give points, and prothrombin you give points on based on this, based on the prothrombin time. If we calculate the Child-Pugh score of this patient based on the level or the labs provided here, if you calculate after this presentation, you can calculate. The presentation will be shared with you. The Child-Pugh of this score of this patient will be 8. C is the answer, based on all these ascites and information provided in the question. So you have to memorize this chart. Obviously, it is important in terms of exam. There can come a question in the exam. Okay. So another case, PL is a 45-year-old man with chronic renal failure. Phenytoin is given 400 milligram per day for seizure. Phenytoin concentration is 13.6 milligram per liter, which is well in the range of 10 to 20. Albumin concentration is 4.2. What do you recommend to do with this dose? Make no changes in this current dose regimen. Keep the total daily dose the same, but change the regimen to 200 milligram BID. Increase the dose for the better seizure control, and decrease the dose to prevent toxicity. So if you see the level concentration is 13.6, you will say it is between 10 to 12. Patient, no need to do anything. But albumin has phenytoin is highly protein bound, So if there is albumin concentration is low or high, it can alter the levels. So 13.6 here will not be true 13.6 if the albumin concentration is low. There is a formula to calculate the equation for the changes in albumin. These are the formula, changes in albumin on renal function. CP on the CP concentration 0.9 into albumin divided by 4.4 plus 0.1. If you calculate this based on this formula, so there will be option will be decrease the dose to prevent the toxicity, because albumin is a little bit low, 4.2. So this concentration 13.6 is not true 13.6. It will come around somewhere 17.8 or 17.6 milligram per liter. So if you keep on dosing 400 milligram per day, there will come a time that this concentration will reach above 20, which is supratherapeutic, and patient may have side effects or toxicity of phenytoin. This is a chart you can consult for the normal levels and what are the sampling or comments techniques for this. Okay, so there is one more case, a 63-year-old man with renal insufficiency, AFib, digoxin for rate control, which is correct. Loading dose, same maintenance dose decrease, loading dose decrease, and maintenance dose decrease. Neither dose should be changed or both doses should be changed. Because digoxin has a very high volume of distribution, has a very high half-life. So in such cases, you do not need to load a patient. You can decrease the both doses, which is D is the correct answer in this case. You can read it here. It will be mentioned in the comments and in this information, drug monograph, which I'm sharing here. Okay, so aminoglycoside, just to give you an idea about this, there is one case, 34-year-old man with chest pain and UTIs, tobramycin 400 milligram IV daily. This is a high dose extended interval. Why do we use high dose extended interval regimen? We know that tobramycin, gentamicin, aminoglycoside can be given BID or TID, but we use in clinical practice once daily dose. What is the advantage? We take the advantage of aminoglycoside concentration dependent killing, and it is less, will not cause nephrotoxicity. So D is the correct answer here. And this is some information about the aminoglycoside. You can read this sampling issues and comments. And this is other medications which have nonlinear kinetics, which are zero order kinetics and follow, which we have to monitor the concentration. You can read this. This will be mentioned in your drug handout, which is provided to you. So this is another question, question 3, which will use the same equation which we used in the first example of vancomycin for MRSA, and you'll get the answer. So let's go over it. So concentration, the current concentration of drug X is 2 milligram per deciliter. Rate constant of elimination for drug X is 0.12. Rate constant elimination is K. What is the approximate half-life of this drug? Is it 6? Cannot be determined, 12 hours or 3 hours. So we know the equation T half is 0.69, 3 over K. Elimination rate constant is given here, which is 0.12. So you can calculate the T half, which is 0.693 divided by 0.12. 5.7 equals approximately 6 hours. So 6 hours is the half-life of this drug. With this, I end my presentation. Thank you very much. I took a few more minutes than the usual. I'm sorry about that. And if you have any question, you can reach out to me through LinkedIn, or my email is given here. You can all find these slides. I will share this slide with the organizers of this activity, and it will be shared with you. But even after that, if you have any question, you can reach out to me. Read your handouts, give more focus to concentration calculation, which we used in the first example, the second example, and the last example of our question. These kind of questions always come in board exam, and you will not have more than 2 to 3, maximum 2 to 3 questions on pharmacokinetics. But that does not mean that you guys should not practice it. I would highly recommend that you practice it 2 to 3 times in your whole study period, if you have decided to study for 6 months, or if you have decided to study for 4 months. Thank you very much.
Thank you so much, Dr. Zeeshan, for your time and effort, sir. We really appreciate your contribution for our program. Thank you so much. We are very grateful.
Thank you.
So participants, this is all for today. So you have your schedules for the rest of the lectures and session. Till then, thank you everyone for your presence. We will be looking forward for your presence in our upcoming lectures as well. For today, thank you so much. Allah Hafiz and take care.
Thank you, everyone.